Hello, and thanks for joining us for this online event. I'm Danielle, an analyst here at the King's Fund. Today we'll be exploring how we best prepare staff for the digital future of the NHS, with a particular focus on artificial intelligence. Before we get started, I'd like to give you a quick introduction to this event. Firstly, I'd like to thank our sponsors of this event, which is Radar Healthcare. This event is live, so please do get involved in this discussion. There are a few ways you can do this. We'll be answering some of your questions as we go along, so please submit your questions on the Slido, which should be in a box to the right of this video. You can also upvote other people's questions there. We'll also be putting some poll questions and some word clouds to the audience, which should flash up during the session. And please also continue this discussion on Twitter using the hashtag KFOnline. We also recommend you check out the resources page, which we will be redirected to at the end of this broadcast. I'd like now to invite our panelists to briefly introduce themselves, starting with Annabelle.
Hi, thanks Danielle. So my name's Annabelle Painter. I'm a GP registrar and I'm also a clinical fellow working at Health Education England and NHS, where I'm looking at how we prepare the NHS workforce for the introduction of artificial intelligence.
Thanks, Annabelle. And Katherine?
Hello, and thank you, Danielle. My name is Katherine Church. I'm the Chief Digital Officer for Surrey Heartlands, an integrated care system in Surrey. I have 25 years experience in digital, but only 2 in the NHS. So I joined the NHS from the private sector in finance, customer service, insurance, you name it. So I've been working with artificial intelligence and machine learning for a little while now, but in different sectors. So it's really exciting to think about how we bring some of that learning into such a sensitive context.
Thanks, Katherine. And now I'll go to Mark.
Good morning, thanks for the opportunity. I'm a recovering clinician. I've been a pharmacist for 30 odd years. I'm an embarrassed management consultant and I'm a proud patient advocate who is trying to make sense of all this new jargon and technology.
Thanks, Mark. And we have Terry.
Hi, I'm Terry Murphy and I've spent most of my 36-year career in and around the NHS, predominantly bringing tech to market. So I was involved with clinicians, moving them from paper to PC, which was quite difficult in the early days. But now I spend my time at Radar Healthcare bringing our award-winning software to market.
Thanks, Terry. And finally, we have Henrietta.
Thanks, Danielle. I'm Henrietta Mbeah-Bankas, still registered as a mental health nurse, and I am at Health Education England as the head of blended learning, but also leading on digital learning and development for the health and social care workforce. Also a clinical entrepreneur using AI to develop a mental health and well-being screening tool.
Thanks all. This is sure to be a great panel to discuss this topic with. The digital future of the NHS is a really exciting topic because it's all about innovation and modernisation. And artificial intelligence is a great example of this. AI can be broadly described as data-driven systems and solutions, often involving machine learning. It has a range of uses in healthcare, including improving diagnostics, supporting public health programmes, creating efficiencies, and generating new clinical knowledge. The government has also recently declared its ambition for the UK to be a science and AI superpower. But what does this all mean for NHS staff and their patients? How do we build confidence in these new AI systems, and what skills and capabilities do we need to equip our staff with? So to start the conversation, I'd like first to go to Henrietta. Henrietta, can you tell us a bit about your work at Health Education England to enable and prepare staff for the digital future of the NHS?
Thanks, Danielle. So Health Education England runs a digital readiness program, which is a huge program, really, looking at how we get a digitally ready workforce to fully utilize the technologies that are available to us, well, presently, and those that we are not even aware of. Now, this program is really looking at it from a number of perspectives, or at least specific groups. So not just thinking about the current workforce that we have, but looking at the future workforce as well. So how do we ensure that our undergraduate curricula has enough digital literacy or digital capability development to ensure that the graduates or the professionals that we have coming out of our training programs are ready to be part of the workforce that's currently using a lot of digital tools. Now, on the flip side of that is looking at our offers to the wider workforce. So as we know it, and depending on which data source you're using, it swings between 1.3 to 1.4 million people. And these are people with differing needs. And how do we ensure that we are developing tools and resources to be able to support them in identifying their digital literacy skills gaps, and be able to have learning resources to support them in developing those capabilities. Alongside that, we need to think about our change leaders and our specialist workforce. Now, our Topol review highlighted from that piece of work that we will need some specialist and technical workforce within the NHS to really support us with our digital agenda. So how are we supporting those specialist workforce and change leaders, such as your chief information officers and clinical chief information officers and others in developing the skills that's required to support the digital transformation. Now, while we're doing all of this, it's also very important for us to think about our boards, because really to implement any digital technology or digital strategy, we need to get buy-in from our boards. So again, we have developed an awareness and leadership training just for boards to really understand what implementing digital truly is, and the move away from it being technology and gizmos to really putting people at the center of everything we do. Now, alongside all of this provision, obviously AI is a key element to this, and it was clearly one of the panels or one of the work streams that the Topol looked at. So as part of that recommendation, we have looked specifically at how we develop AI capabilities across our workforce and across the pathway, really right from pre-registration or future workforce to our board leaders. And Annabelle, I know, will talk a bit more about the work that she and colleagues have been leading on within the AI space. So I think, in effect, we've got lots of work going on across the pathway, right from our future workforce to our board leaders, developing tools and resources to really support our workforce across the piece. Thank you.
Thanks, Henrietta. It's great to hear about the work already happening to introduce our NHS staff to the digital future. So I'd like now to go to Annabelle to talk more about AI. So Annabelle, can you tell us from a clinician's perspective how you think we should go about preparing staff for the introduction of AI?
Yeah, sure. So as Henrietta said, this kind of fits into a bigger picture about digital readiness and about digital literacy. But on top of that, we're going to need to be thinking about AI literacy amongst clinical staff. And this, AI literacy needs to apply to everyone. So it needs to be accessible to those clinicians who are currently practicing, but also embedded in the undergraduate curricula of future clinicians in training. And in terms of what this AI literacy would practically look like, a lot of this comes down to familiarity with AI, appreciation of what AI actually looks like in healthcare. And we know that the confidence of clinicians is linked with this, and the more familiar people are with the practicalities of what AI actually looks like, the more confident they are in using AI. But beyond that, a lot of it is about data science skills. So it's about clinical informatics, it's about data science, and it's about embedding this skill set within training for clinicians. And it's also about making sure that we have the right training pathways and we have the right job roles and opportunities for these individuals. And again, taking from what Henrietta was saying, it's about educating the boards to make sure that people are aware of the value of this skill set and the value of specialists with this knowledge, and make sure that these people are incorporated into teams and that they're given the right opportunities and the right responsibilities within trusts to drive forward AI innovation. Then when we think about clinicians specifically, we need to think carefully about the clinical decision-making process when it comes to AI, and think about how the use of AI technologies can influence that. And this is going to be something that's really important when we think about our clinician education, because there's a lot of potential for biases, such as automation bias, coming into play with the use of artificial intelligence. And what we want to do is make sure that clinicians are not over or underconfident when using AI, but have the appropriate level of confidence with AI to be able to make a value judgment about when they should be using AI outputs to influence clinical decisions and when they should be ignored. And that skill set involves learning critical appraisal techniques for AI, and learning when AI is and isn't likely to fail, and the kind of things that are likely to influence AI behavior. And finally, a really important education point when it comes to clinicians is about their communication with patients. We really need to make sure that the clinicians feel confident in having conversations with patients about artificial intelligence and helping them make a joint decision with patients about the care that they get and the decisions that are made about them. And that will include information about data privacy, and data sharing. And what we want to do is empower clinicians to become AI counselors and to be able to help their patients make the best possible decisions about their health.
Thanks, Annabelle. And I'd like to come to our first question from our audience to both Annabelle and Henrietta. There might be some people out there in the NHS who are more skeptical about the digital future of the NHS. How do we encourage those staff to adopt digital technologies? So either Annabelle or Henrietta, do you want to come in here?
Do you want me to start? So I like that question on the basis that actually for all the work that we are doing, we've categorized our users into 4 distinct groups. And we have done that from our discovery to really understand how we tailor our intervention. So we're very much aware that we're working with a group of people who are not very positive about digital. So they are negative about digital and as a result are disengaged. And I think we all know somebody that says, I don't do tech. So that's the group that we're talking about here. Now, on the other end of the spectrum, we have got people that say, bring it on. When is the new iGadget coming out? When is the new this coming out? How do we maintain that engagement and keep them enthused and keep them driving the digital transformation? Now, in between these two ends is our middle or our neutral group of people who say, actually, if the tech is there, great. If it's not, give me my pen and paper. So I think what we're saying is we are very much aware that we're dealing with different digital user personas within our workforce, including a 4th persona who are digitally excluded. I mean, people talk about, I live in Cornwall, I can see the mast, and yet my access to internet is poor. So how do we ensure that we have targeted the right interventions to all of these groups to ensure that we bring everybody along and not just the digital enthusiasts? So I think there's lots of work to be done, and we're starting to address some of this using opportunities such as championship. So a bit of hand-holding, and my medical colleagues usually say, see one, do one, teach one. So once people have seen how things are done and they try it, sometimes all it takes is what can digital do for you. So it's a language thing and being able to offer something else.
And Annabelle, do you have the same perspective from a clinician's perspective? Would you say the same to your colleagues who might be skeptical about digital future or AI?
Yeah, I mean, I completely agree with everything Henrietta has said. I think that there's definitely something in here about leadership and the focus on educating leaders to drive the introduction of technology in a way that brings their staff on board. I think there's also something about how we educate users about specific technology, because at the end of the day, this technology should be improving the quality of work life for clinicians and improving outcomes for patients. And I think that's what we really need to get across is how actually the introduction of this technology will make the healthcare system better for clinicians and for users. And if we can really drive home that value point and make sure the way we introduce technology does do that, and we can show that, I think it's much easier to get people on board. But we naturally will always have an adoption curve, and that's true of any technology. I think it's just important that, as Henrietta was saying, we can use the kind of early adopter people who are really enthusiastic about technology to bring forward those who are more towards the laggard end. So kind of show their colleagues the value and then be kind of exemplars for using technology.
Thanks, Annabelle. And now I'd like to get a slightly different perspective. So I'd like to go to Katherine. Katherine, at an ICS level and who's someone who's working across a variety of settings, what do you think the main benefits of machine learning and AI could be?
Yeah, no, excellent. Thank you. Can I say how much I agree with the previous points? Technology without a comprehensive plan for engagement and adoption and deployment will never deliver any benefits. So we absolutely have to take people on this journey with us. I think from an ICS perspective, I'd probably like to take a slightly wider lens than just the clinical lens on artificial intelligence. And just also reflecting on the years that I've spent working with machine learning services. And essentially the core benefits that you're going to look for is the ability to streamline and automate certain repetitive processes. And those will bring cost efficiencies, time efficiencies, enable human beings to actually focus on doing more value-add activities as we're taking some repetitive processes and administration out of their day-to-day work. The other thing that we look at is creating some standardization and removing the potential for human error. And I think that one's actually probably a little bit more contentious in a healthcare situation because the complexity and variety of the inputs that come into any decisions that we might ask a machine to do for us. And I think the third major area, and again, at an ICS level, is that ability to predict. So if we've got an ability to understand what's happened previously, then we can use that data to start to predict demands of service management, for example. If something happens in one area, what impact is that likely to have in another part of our system? So I think those are the core three benefit areas. And I'd just like to talk a bit about some of the applications of actually really simple artificial intelligence, so machine learning, that we're deploying across the ICS. So thinking about simple chatbots, for example, we're piloting a range of chatbots in adult social care. So in our citizen engagement channels, where we're trying to understand the utterances and what people are asking us for, and to be able to understand that and either provide some automated replies, or sometimes it's about signposting to other services. And we're getting some really good success in that. And that can take quite a bit of frustration away from citizens who are trying to navigate quite a complex system to get answers. And what we can also look with, which I've done in the past, is actually having a function that's self-learning, that's a bit more intelligent. So when you've seen that on other sites, when people say, was this information useful, then that is training the algorithm and the machine to get more intelligent and understand more. I think also then, as we're thinking about maybe further away from the clinical end, there's a huge amount of value that can be gained from robotic process automation. So actually using bots to integrate between different systems and carry out administration tasks without the need for human intervention. And it's really basic. It's a really basic level of AI, but I think it's one that has enormous potential. And we've got a centre of RPA excellence, and we're working really closely with James Davis at the Royal Free, who is creating a whole set of free to use for the NHS assets so that you can deploy robotic process automation at scale. So that's really helpful. And if we think about the amount of time and effort that's put into administration, managing appointment changes, standard reporting, I think again this technology has got some real benefits there. And then finally, I'd probably come in more into the clinical space and think about clinical triage in primary care as being a really good example of where we can use again some business intelligence, some business rules, and some AI, some basic AI to again in primary care. We're looking at this with in a number of places, where we can again actually understand the situation that a patient may be presenting us with and signposting that individual. They may not need to see a doctor, they could see a pharmacist. They may not need to see a doctor, they could see a physiotherapist. So it's that intelligence to try and understand these presentations and what an end disposition point might be. So those are some of the examples. I know other colleagues will talk much more about digital imaging and clinical imaging, which have a huge part to play as well. But I think they're probably some of the more widespread areas that we are looking, that have got the real opportunity to change things in the right here and right now.
Thanks, Katherine. It's great to hear some of the examples of how this AI could be used in the future and also at the moment. And we've had a few questions about how far away we are from this AI and digital future. Where are we as a starting point? Are we still at the basic point of digital literacy and IT infrastructure, or do you think the AI and digital future is near and coming soon? So, Katherine, I'd like to come to you.
Yeah, so I think the future is now. I think the future is absolutely now. There's some extraordinary work, some really exciting work which is going on in the AI lab. So some the NHS artificial intelligence lab, which of course Annabelle works with really closely. There's some amazing programs going on. Our hospital, Royal Surrey, are involved in a scale clinical imaging program for thoracic images. So there's some real scale applications, and I think that's the point for me. For AI to be impactful, it needs data, it needs scale, it needs clean data that you can bring together. But there's some really exciting scale work that's happening in the clinical imaging space, and I think there's some really exciting work happening in the automation space and the customer engagement space. So I think in pockets, but in significant pockets, the future is today.
And Henrietta, would you agree on that?
Yeah, no, absolutely. I think we're talking about AI in terms of clinical decision making and use, but what we are also missing as well, as part of the whole process, we are also starting to utilize AI in actually delivering education. So if I think about our digital literacy self-assessment diagnostic tool, we're using an AI-powered signposting tool that allows targeted learning to be recommended to the individual. So historically, you do an assessment, you go and find learning. What we are now doing is using that AI capability to actually say, based on your assessment and identified need, this is the recommended learning for you. So I think AI has number of, we can use it in a number of ways, not just in clinical practice, but in education as well.
Thanks. And Annabelle, did you want to come in on this one?
Yeah, sure. So I just kind of want to echo Katherine's point that the future is now, but also say, in answer to this question about what stage are we at? Are we at digital literacy? Are we at AI literacy? Are we at the actual introduction of AI? The answer is we're actually at all of those stages at the same time. There's a lot to be done still in digital literacy, and also just leveling up of our IT infrastructure across the NHS and improving the data quality and data sharing that we have within the NHS. And that's really important work. And by doing that, we will be able to accelerate what we can do with digital technology and with artificial intelligence. That being said, there's already artificial intelligence being introduced into the NHS. It's already being used in the NHS now. And part of what we've been doing at Health Education England is a horizon scanning exercise, looking at what technology is coming in the next few years. And there's a lot on the horizon in the next sort of 1, 3, and 5 years from now. So with all of it's happening at the moment, and we need to work on all of these stages concurrently.
Thanks, Annabelle. And Terry, did you want to come in?
Yeah, I think Annabelle's still part of my thunder there, but I wanted to also echo what Katherine was talking about, because I think on the front line, what I'm seeing is that we're kind of knee deep in AI at the moment. It's been around for a while, and I guess people adopting AI. We've been doing this for years with our phones, with our Surrey, with our Nest, whatever it is. So we're kind of knee deep in that tech. And I think over the last 18 months, certainly from my perspective, I've seen it being more adopted in the NHS.
Thanks, Terry. really interesting topic to be talking about. And we've been talking a lot about how we're preparing staff, but they're not the only people involved in AI and this new digital future. So Mark, now I'd like to come to you. Can you tell us from your perspective what some of the concerns patients might have about adopting AI, but also some of the benefits patients might see?
Sure, yes, and thank you to you and the King's Fund and Radar for asking, a patient, as perhaps we all are in some respects, although you've got to be careful how you say that, but to actually be on the panel, I think that in itself actually says that there is a sea change in how we're approaching healthcare. So we're not just doing to, we're trying to do with, and even do from patients in terms of real world evidence and I suppose patient innovation. I just want to go back first before we touch on patients to the sort of staff issues that have been brought up by colleagues. And I remember many years ago sitting in a meeting as a patient rep, and a GP from Oxford who was a lovely guy but said, "Oh, I don't do IT." And I sort of put my hand up and I said, "Listen, I'm the patient person, what do I know? But can I just challenge that?" He said, "Sure." I said, "Do you use the stethoscope?" And he said, "Yes." I said, "Would a doctor who couldn't use a stethoscope perhaps be seen as negligent?" And he went, "Yes." And I said, "Well, forgive me for saying this, but a GP or any clinician who now says, 'I don't do IT,' in my head is equivalent to a physician who says, 'I don't use a stethoscope.'" Now, I'm not saying, and he took it very well, but I think something about it being acceptable to say, "I don't do IT," isn't really acceptable anymore. It's a fundamental way of doing business, and I think we need to get away from this acceptability of saying I don't do IT. That's not to say that people have data poverty issues, people have data literacy issues, etc., etc. I'm not undermining the need for people to be have competence and to be upskilled to use it. What I'm trying to suggest is the acceptability of saying I don't do IT really is something we need to move away from. But I think it's difficult because in my day job, I support startups, and a lot of them have wonderful technology, but don't quite know what the solution, the problem is they're trying to solve. And I sometimes think with technology, we can get driven by the ability of what the technology does without really understanding its reality in use cases, in hospitals, in GP settings, and social work, etc., etc. And I think we need to be driven by what is out there and what is needed, not just by the technology. And we need to be careful with how we talk about things. I mean, when you say to me AI, I suddenly go, artificial intelligence, that's what we used to joke pharmacists were, they were artificially intelligent. Oh, I'm going to get into trouble for that. But, what does it mean? It's yet again a terminology. I've had a debate for many years with my pharmacy colleagues that we use a term called medicines optimization. Well, why are we using professional jargon when we could just talk about medicines taking? Let's see what it is on the tin. We now get into, well, it's machine learning, it's not machine learning. So I think we need to be very careful in our professional realms about the terminologies that we use. Is AI the same as autopilot, for example, on a plane that we've all been very happy with for many, many years? I do remember 20, 30 years ago as a little kid, the pilot saying, "I'm now switching to autopilot," and you could hear this like intake of breath from all the passengers, like, "Oh my goodness me, a machine is going to land the plane." We just take that for granted now. We're all still excited or maybe terrified of autopilot on cars, and me sitting there watching a video while my car motors down the M60, not quite. But how do we make this something that's a little bit more acceptable? Now, I look at the NHS and sometimes wonder, again, not close enough to it, but I think the NHS mandated that all trust hospitals have a patient portal. Well, what is a patient portal? What benefit does it bring? And why would I, as a patient, want to get involved in a patient portal? Build it, they will come. Well, you won't unless I know what the benefits are. So I think rather than keep talking about the technology, we need to turn it on its head and talk about what are the benefits that the technology brings to society, to patients, to clinicians, to social care, etc., etc. And I think to me that's absolutely key. And then really the last point for me to make is I don't think it's a case of digital literacy of clinicians and social workers, etc., etc. It's the digital literacy of the entire population. And in the same way that clinicians struggle a little bit with shared decision making, I do think, oh my goodness me, AI counsellors, well, they struggle to often share decisions around diseases. How much more so might they struggle about being coaches and shared decision makers when it comes to AI? So let's make sure that we've taught our clinicians to be less paternalistic, to move away from just being carers to also being coaches, and perhaps asking patients, clients, how can I empower you to become more able to manage your own health? And in some cases, some patients will turn around to doctors and say, well, I'm more digital literate than you, or I have a rare disease and I know more about my rare disease than you do as a general practitioner. So I think it's a case of we need to look at recognise the shared responsibility of digital literacy, and for us all of us to learn from each other, not just assume that because we have certain, in inverted commas, professional roles or professional training, we are the ones that are able to distill the knowledge. I think it can come from lots of different places.
Thanks, Mark. And building on your point about making sure we explain the benefits of AI and digital, Terry, I'd like to come to you now because you've got experience of implementing AI in the NHS. What do you think the main benefits to both staff and patients will be?
Well, I guess, look, there are many benefits, and I guess as an organisation, one of our mantras is that we kind of take a consultative approach, because remember, the process doesn't start with the end user. It always starts with a procuring body. So my role, I deal with procurement to deployment, and there are a lot of moving parts within that. And this might be slightly controversial, but I don't really think there is a challenge moving to AI. I think the challenge comes from the vendor side. So how do we position it? And this is kind of going off the back of what Mark says. I was on a call the other day. We had 17 faces, much like we do today. Each one of them had a different interest as a stakeholder. Now, what we do as a vendor, I guess, is we speak to each individual there. So the end user or the person on the front line, a clinician maybe, doesn't necessarily need to know how AI works and what's built in the back end. They just need to know how it's going to help them do their job more efficiently. So I can talk about things like data-driven events and predictive analytics, because that kind of speaks their language. But if I went into the back end and said, well, this is how the algorithm's built and put together, it means nothing. And then that kind of, in some respects, alienates the end user. Because what we want to do is garner interest and uptake of the software, because we know the benefits to them and their patients and the NHS as a whole. That's going to make a real difference, and that's what we're about.
Thanks, Terry. And it'd be interesting to hear some examples. So, Katherine, do you have any examples from your work in the ICS or from your other roles?
Yeah, absolutely. And I think really to echo both Mark and Terry's points around ensuring that the product or the service that we are designing meets the needs of citizens. I was just reflecting then as people were talking to what extent Amazon explained how it used AI in terms of encouraging us to buy more stuff or enabling us to track where our parcels are, or the various recommendations engines that we're getting all over the place. And I'm not saying that is the approach that we should adopt. I think if we actually co-design and engage with people in determining our solutions, and I'll give you an example of where we've done that, then actually we probably don't need to explain what AI is doing in terms of the technical foundations of it. What we need to explain to people is how decisions are being made about care, who is looking at that information, and what's happening to that information. And the example I'd like to give you is a program called TIM for Dementia in Surrey. And this started as a research program, an Innovate UK funded research program to see whether we could spot and predict signs of deterioration in early onset dementia in frail elderly adults was our cohort, and it was with the university, one of our trusts, and a large group of citizens. and we co-designed an integrated eco-environment of medical devices. And they are bringing data back into the machine learning platform, and that platform is actually mining and understanding that data and looking for patterns, and then predicting when we think something might deteriorate. So the things that we're looking at is people's behaviour, their movement, some physiological symptoms. And as we did that, of course, we wanted people to collaborate. We needed people to collaborate and use the devices, have the devices in their home, them or their carers log on to the portal and give us information. So we had to design it in a way in which it was useful and it would be used, not just put to one side like telehealth devices often can be. And as part of doing that, we were able to have some of those open conversations to say there will be clinicians at the end of the phone, but actually that initial monitoring is going to take place via our AI platform. And if we notice things that are vastly different, then that will be alerted, and that will be escalated to a clinical monitoring team who will reach out. And that's been really successful in terms of alleviating people's anxiety, alleviating carers' anxiety because they know someone is there and monitoring and helping, but also giving that space to have that really important conversation with citizens to say the model of your healthcare is going to change very slightly, and we need to have that open conversation. And we've actually built on that product quite significantly during COVID and extended it to some remote monitoring for COVID symptoms as well. So that was a really practical example of how we went about it.
Thanks, Katherine. And Annabelle, do you have any similar examples from a clinician's perspective or anything you wanted to add in there?
Yeah, I think something that might be helpful just to reflect on from what's been said is really the value here about product-specific training and education, and it has to be tailored towards each individual use case and each individual implementation of that product. And that's really important because you need to know, so as a clinician, as people have said, you don't necessarily need to know the details of the way an algorithm was designed or trained, or necessarily whether it's even AI or not. And sometimes that term's not that helpful. You just need to know that there's some kind of algorithm that's making a decision. But what you do need to know is how that AI should and shouldn't be used, and its potential limitations and the situations in which it's most likely to fail. So for example, to use the example that Katherine was giving, we might be using this to remotely monitor people, say at home, for deterioration, but it might be that certain individuals with specific conditions, it wouldn't work so well on, or if they're doing certain activities at home or moving around in a certain way, it's likely to confuse the AI algorithm. Now, these are the points that are going to be really important to teach both the end users, potentially the patients, but also the clinicians who are interpreting it. And that needs to be tailored to the particular implementation. And it might mean that you do need a certain background information, for example, in how algorithms are trained, because if you know that it was trained on a certain cohort, and then you're trying to use it on an individual setting which is different to the training cohort, it might be more likely to fail. So yeah, I think there needs to be a focus there and make sure that the training is specific and is bespoke.
Thanks, Annabelle. And Terry, did you want to come in on this as well?
Yeah, I was kind of thinking about organisations, and one of the things that we tend to look at is where they're reactive at the moment to issues that might arise, and then actually moving them to a place where they become proactive by using AI and machine learning. And I'm thinking of a particular case where we look at outbreak events, for an example. So you may be adding information into our system, and it's alerting somebody centrally. Well, look, this has happened on three or four occasions over the last couple of days. Perhaps an event outbreak might need to happen, and somebody needs to be informed about that. And that's how I guess we start to mitigate risk in an organisation. I'm thinking about COVID because it's very topical at the moment, but our systems are able to see that and create that event and let the right person know at the right time, so we don't get this explosion of data over a period of time that's a bit nonsensical and you can't really understand it. And I guess coming back to something Mark said as well, it's almost like you become a coach in scenarios. So asking questions, Mark, like you did about the stethoscope, it's very simple to ask the questions like, if your system was able to do this, would it benefit you? And the answer is simply yes or no to that. And I think the more yeses that you can get to your questions, the more engagement that you've got.
Thanks, Terry. And Henrietta, did you have any reflections on this?
Yeah, no, absolutely. I think we've had lots of discussions and focus around training, around the technology itself. But I think for us, we have almost called our program digital readiness, because the focus doesn't always sit with just skills, but the attitudes as well and the cultures in which people are working. So I think for me, we know that if people are skilled and trained, but haven't got the confidence and the motivation to use the training they've got, then really highly unlikely they would be utilizing any of the technologies that's available. So I think it's important, alongside all the conversations around developing digital capabilities or literacies, AI literacies, ensuring that, you know, the tech is explained to people, that actually we've got cultures in our individual organizations or across ICSs that are facilitative in terms of processes, but also open to sometimes people, you know, things failing and learning from the failures. And I think that's not something we are particularly good at doing within our health systems, because everything has to work. But sometimes actually there's a lot more learning when things haven't worked. So I think what I'm saying is we need to think about the culture in which all of these discussions and the education and training and implementing these tools are happening in.
Great, thanks, Henrietta. And I'd like now to move on to another question we've got in from our audience. So there's a question here about what the plans to manage any risks or biases that might come with AI. Are we at risk of creating biases with the use of AI? And do we need to educate our staff or patients about ethics, for example? So shall I come to Katherine first on this question?
Yes, thank you. I think any conversation about any kind of machine learning or AI without having a discussion really around ethics would not be the right thing to do. And if we look at the fundamentals of taking vast groups of data in and making some determinations or decisions or predicting the future from that data, then there is inherent bias. So how we collect that data in the first place, where that data comes from, who is open to sharing that data, will all impact in a very significant way on the way in which we develop the AI. And I suppose one of the things that just occurred to me there is when we're thinking about maybe clinical triage, for example, or some of the kind of like chatbot facilities, what you may end up getting is people who are digitally literate and confident and happy to go online or happy to engage with some form of clinical triage. And that then convinces us, so they come back and they're happy to do so, and that convinces us that it's the right thing to do more of that. So I think we need to be really, really careful at every stage of the construction and deployment of any AI project to make sure that we're always alert to any kind of data bias or confirmation bias.
Thanks, Katherine. And I'm wondering if this is a concern that patients might have as well. Mark, do you think there's concern from patients about the ethics of AI?
I think we need to understand what AI is before we even get into topics of ethics. I mean, I play a word game on my phone when my mum was alive, and used it actually, funnily enough, as a sort of unofficial caring tool. So I would know that it was a Scrabble type game, and if mum didn't respond within 15 minutes to the word that I played, I began to get a little bit nervous and sent her a text. And why am I telling you this story? Because it's an interesting way that we're using technology as carers to look after infirm patients, even through the back door. So mum wasn't really aware of the fact that I was sort of watching her responses to a word game in order to see how active she was. But why I'm bringing it up is because all of a sudden a purchase that I'd made for one of my kids on Amazon, I think I'd bought them a Beano manual or something, suddenly started appearing all the time in the word game that I was trying to sort of play with mum. And I found that slightly intrusive. And therefore, I think where we're at is privacy policies. And I don't know anybody on this call, I'm sure there is somebody, but of the many attendees, how many of us have really read all the privacy policies, and all that tiny little print? So I think before we even get into topics of ethics of AI, I think we need to have a clearer understanding of what we're all signing up for. Because I've obviously ticked a box somewhere in Amazon that allows them to advertise purchases to me in apps that I'm using on my phone. So that brings up some questions for me, not so much about the ethics of AI, but about the ethics and the business practices of some of these very large companies that we're all associated with and using. So I need to understand what I've signed up for. I need to understand trust there. And that's just in a game, never mind when it starts coming to my health or my wealth. So it's back to basics. I think it's really understanding what we're talking about, what is basic digital literacy. And I think we have, in a way, a bit of a mountain to climb. It's okay for us articulate, middle class, educated patients. But what we don't want digital technology to increase health inequalities. We want it to close the gap, not widen it.
Yes, definitely, Mark. And Annabelle, would you like to come in on some reflections on Mark's points?
Yeah, just to say that I think ethics and bias has to always be considered at every stage when we're thinking about the introduction of artificial intelligence and how we educate people about artificial intelligence, because it fits in at so many stages, whether that's the way that AI is designed, the way that it's validated, the way that it's implemented. So it's just something that needs to be thought about throughout that process, and we need to make sure that the people who are making decisions have always got this, are always considering it. And I certainly think there's an argument for including this in any kind of regulation and validation of AI that's used within healthcare, to make sure that at the stage that it's introduced, it's already gone through some kind of assessment for bias. And certainly there are many bias standards that are being looked into at the moment. But I'd also like to kind of follow on from what Mark was saying about how AI should be about reducing inequalities, and actually it can be used to help counter bias. And in October, NHS recently announced that there's 4 projects that have been given £1.4 million funding that are looking at how we use AI to try and counter bias within healthcare. So I think it can go both ways, and it just needs to be something that's given the right attention and focus.
Thanks, Annabelle. Yes, a really important topic when we're talking about AI. I'd now like to move on to another one of our audience questions. Actually, a few questions here have been about how do we give our NHS staff the headspace to think about the digital future and the AI? How do we keep them engaged and enthusiastic about the digital future and AI when there's a lot of other competing demands and pressures on staff at the moment? So Henrietta, I might come to you first. How do we keep staff engaged with this topic?
How do we keep staff engaged? I think, I'm a trained nurse, but I've had a career in digital in the last few years, and I keep myself engaged with sometimes dipping my toes into things to see, what's this all about? And I think our program, our digital readiness program, is putting a lot of resources in. As I said, we've got a whole training pathway to allow individuals to do just that. So as a clinician, we are in an era where people don't just want to be doctors or nurses or even our non-clinical staff. People are getting interested in, portfolio careers, and digital being one of them. So there are real opportunities to test bite-sized learning that's out there to see, is this an area of interest that I want to pursue more? Look at other training offerings that we've got. Some will lead to certification. Others are just training that you really are interested in and want to understand more about it. So I think there are lots and lots of offerings at the moment. And once you are very enthusiastic about it as well, you can lead and support others, because we do know that, people who are, less digitally literate prefer to have peers guiding and supporting them into that. So I think that there's lots of opportunities alongside the day job, but also seeing the value that those digital literacy skills and those technological tools can actually help you do the things that you do on a day-to-day basis. So it's part of it, not the other thing, really.
Thanks, Henrietta. And Terry, would you like to comment on this point?
Yeah, I think I agree completely with what Henrietta said, but I think taking it a step further, I guess today, when you're putting clinical systems or non-clinical systems into the NHS, I think we need to move away from the vendor saying this is the way that you need to do it, this is the way that it should be done. Rather, I think look at the unique requirements of each of those organisations and build your platform to their requirements. That's when you get the engagement, a good user interface. So I've seen some products out there that do 7 or 8 different things, and all of the processes are completely different. And I think what we need to move to is a system where each of those processes looks familiar, feels familiar, and we know from the data that you get engagement based on that. So a great user interface that is built to your unique requirements.
Thanks, Terry. And it'd be interesting to hear, Katherine, your perspective as well, as someone as a leader in an ICS. Do you think this is going to be a challenge to implement digital and AI?
Absolutely. I think what's really interesting, and I've found this in previous sectors, is that some of the people who are most resistant, I'm not talking about the NHS now, I'm talking about customer services or front office in banking or back office in insurance, some of the people who are the most resistant to using new digital platforms at work they've all got iPhone 12s and are all using technology. So we're and I don't think there's any kind of reluctance. I think it is exactly to Terry's point, is have we ensured that we have design systems that are as easy to use as Google, for example? Have we made time to train people? So when we're deploying new systems, is enough time given to people to be able to really adopt that technology? And are we actually giving enough elapsed time to allow people to move from one way of working to a different way of working? Because that can be quite threatening. Again, coming back to a customer services sector, we had people in contact centres who were terrified that their jobs were going to disappear as a result of this. Now, I don't know that we're doing anything at scale enough, and there's so much work in the NHS, so I think it's unlikely that would be the outcome for an awful long time. But there will be reasons, there'll be reasons behind that. And I think poor design, poor ability to integrate systems into other systems. So if you've got to have 5 or 6 different logins and different levels to actually access the tech that you need, and then it's really hard to find a patient record or a citizen record. So I think there's a lot around the design of the platform. There's a lot about how you access that and integrate that into the rest of your day-to-day activities. And then I really think there's something about giving staff the time to adapt, the space to adapt, and almost that mental headspace to acknowledge that they're going to move to a different way of working. And all of that takes a long time. And unfortunately, time is not something we have a huge amount of right now, is it?
Yes, definitely. And Annabelle, is there anything else you would like to build on from this question?
Really just echoing what others have said. I think user-centered design is so important, and the point that Katherine was making about integrating with existing systems is really crucial to make sure that these if the technologies should be intuitive to use, it should be easy to pick up. So actually, you shouldn't need to have to be like struggling to engage people to use it, because it should be really, really simple and easy to use. So that's one fundamental thing about the technology that is adopted. And then it's also about protecting time for this kind of training and adoption, which it's not easy to do that within clinical settings, but it is important that initially you give people the right time they need to come to learn about new technology, so that they can then adopt them much faster, and it can be a much smoother process. Yeah, so I don't think I've got anything more to add to that, really.
Thanks, Annabelle. And we're almost out of time today, so I'd like to invite our speakers to give their closing reflections on this topic. If there's one thing you want the audience to take away from this discussion, what would it be? So, Katherine, I'll come to you first.
I think I'm going to finish on that thought there, that change can be daunting. Digital can be daunting for a whole range of reasons that we have covered previously. So really think about the integration of any digital technologies or artificial intelligence solutions into existing ways of working, and give people time to go on that journey with you.
Thanks, Katherine. And Annabelle?
So I think my closing statement would be that I don't think clinicians are going to be replaced by artificial intelligence, but I do think that they're going to be replaced by clinicians who know about artificial intelligence. And I think that it's time that we prioritise the education of our clinicians to make sure that they have the appropriate data science and health informatics skills to be able to use digital technologies safely and effectively.
Thanks, Annabelle. And Henrietta?
Yeah, no, I think as we start to do all of this work in terms of implementing digital, looking at AI, for me, the focus, if you take nothing away with you, if you're a transformation lead, you need to think about three things: the people, the process, and the tech. So if you educate people, but with wrong processes and the wrong technology, it doesn't work. So you've got to do the three hand in hand to be able to get the best outcomes.
Thanks, Henrietta. And Terry?
I think if we look at the last 2 years, I read a study that said that tech in the NHS has moved at the pace of 10 years. And I guess my closing remark would be that if you're using systems at the moment and you're thinking, well, perhaps, is there something else I can do? Can we do something with what we've got? Or do we need to look in a different place? I think now is the time to assess what you're doing and ask if we can do it differently.
Thanks, Terry. And Mark?
Yeah, just think person first, whether that's a clinician, a social worker, a patient, a carer. Can we think about what the benefits of technology bring to them and explain it in a way that makes sense to them, and for them to engage in co-creation and consultation and the process, rather than talk about the back office, the technology and all the rest of it. So I say put person before the technology.
Thanks, Mark. And that's pretty much all we have time for today. So thank you for our speakers for joining, and thank you from the audience for watching and for asking your questions. If you've enjoyed today's event, please do share the link with your colleagues who can register and watch this event on demand. We really value your feedback, and we're always looking for ways to improve our events. So there'll be a feedback button appearing at the bottom of your screen, and a survey link will be sent out shortly. And finally, I'd like to thank again our sponsors for this event, which is Radar Healthcare. Thank you, and enjoy the rest of your day.